All right. Well, welcome back to the Cribsiders. This is a Medscape video recap summary of one of our recent podcast episodes. So, what are we reviewing today?
Yeah, we are here today to talk about childhood onset lupus. In this recent Cribsiders episode, we chatted with Dr. Rebecca Sadoun. She is a pediatric and adult rheumatologist at Duke.
So, how do pediatric patients with lupus tend to present?
This was one of the biggest take homes for me from the podcast. Patients with lupus can present with a pretty broad range of symptoms. It's actually a very heterogeneous disease. Fever, fatigue, weight loss, joint pain, and stiffness, those are the most common presenting symptoms, but patients can also have a rash. In fact, skin findings are present in about 2/3 of children with lupus. Some of those common skin findings are the malar rash, discoid rash, alopecia, or oral or nasal ulcers. The other thing when thinking about how patients present that Dr. Sadoun advised us is to think about the timeline. So symptoms that are lasting hours to days are not really concerning for lupus, but if symptoms have been lasting for weeks to months, lupus should definitely be on your differential.
So, if it's on our differential, what type of initial laboratory evaluations is suggested at this point?
Yeah, I think it depends on where you are. I think in the primary care clinic, certainly starting with the CBC and inflammatory markers is a good place to start, as those tend to have abnormalities in patients with rheumatologic conditions. But if you are looking to make a diagnosis of lupus, there are actually 5 tests that you need to help with that diagnosis. So that would be the ANA, anti-double-stranded DNA, anti-Smith, C3 and C4, and anti-phospholipid antibodies. If you can get a patient into a rheumatology clinic within a few days, it's definitely reasonable to wait on this expensive workup. But if the index of suspicion is really high and it's going to be months before you can get a patient into a pediatric rheumatologist, primary care doctors can absolutely start this workup. Another thing that Dr. Sadoun told us is that there are some states in the United States that actually don't have a pediatric rheumatologist in the entire state. So there's definitely some cases where primary care physicians and pediatricians need to start this workup.
Yeah, that makes it a little hard. So, let's talk a little bit about epidemiology. Are there certain patient populations that are more likely to have lupus?
Absolutely. So lupus is pretty rare in children before the age of 9, but the incidence increases as children get older and into early adolescence and late adolescence. There is also a predominance for females, so 3-to-1 before puberty, and that actually goes up to 9-to-1 females to males during puberty. There are also some races and ethnicities that tend to have higher rates of lupus. So African American, African, Native American, Pacific Islander, and Latinx, those populations all tend to have higher rates of lupus. The other thing we talked about is that having a family history of rheumatologic disease does raise the pretest probability, but there are certainly many patients who don't have a family history that end up with a diagnosis of lupus.
Gotcha. All right. So, we have an index of suspicion based on our patient populations. We have sort of how some of these lupus patients may present, and then we've done a laboratory evaluation. So based on all this, are there any specific guidelines or criteria that we can then make that final diagnosis of lupus?
Yeah, we talked about a couple different criteria on the episode, but Dr. Sadoun told us that the 2012 SLIC criteria, SLICC criteria, tend to be the most commonly used in pediatric practice. I'll go through just the general clinical criteria. There's a little more detail if you want to look it up, but the general clinical criteria for diagnosis include mucocutaneous manifestations, serositis, joint disease, cytopenias or hemolytic disease, renal involvement, or CNS involvement. And then the lab tests that help with that diagnosis are the ones that I already mentioned, but I'll say them again because it's important to remember. So that's the ANA, the anti-double-stranded DNA, anti-Smith, C3 and C4, and anti-phospholipid antibodies.
All right. So now that we figure out diagnosis, let's talk a little bit about treatment. What medications should we be starting?
Every patient with lupus should really be put on hydroxychloroquine if they can tolerate it, and that's a medication that helps prevent flares. However, if a patient is having really significant symptoms when they show up, or you need a medication to work quickly, then you're thinking about starting steroids. And then as soon as you start steroids, you're thinking about what medications you can use to get the patient off steroids. So those are disease-modifying anti-rheumatic drugs, or DMARDs. The most commonly used DMARDs in pediatric lupus are methotrexate, mycophenolate, and azathioprine.
And so in this episode that we're recapping, there was another thing that we sort of talked about that I was wondering whether you could clarify. What's a SLEDAI score?
I think you said it right. So I won't go into too many details, but this is the Systemic Lupus Erythematous Disease Activity Index, and it's actually a tool to help stratify the disease severity, and it can help you guide therapy. So it's primarily used for pediatric rheumatologists, but certainly for interns or residents or primary care doctors who want to impress your local rheumatologist. This is something to look into.
That's a good one. So do we have any final pearls and takeaways from this episode?
Yeah, one thing that I definitely didn't know before is that infection is one of the highest causes of death in patients with lupus. So as a primary care doctor, one of the best things you can do is make sure your patient is up to date on routine vaccines. And the other, I think, big take-home point that Dr. Sadun mentioned several times during the episode is that, ANA is actually a very useful test if your index of suspicion is really high. It's very sensitive for lupus, but definitely not specific. And, anywhere from 10 to 15% of healthy children will actually have a positive ANA. So if your index of suspicion is low for lupus, you should absolutely not be ordering an ANA.
Gotcha. Well, thanks again for joining us for another Medscape video recap of the Cribsiders Pediatric Podcast. To listen to the full episode, you can download the episode and others on any podcast player or check out at our website, www.thecribsiders.com. Thanks for tuning in, guys. Bye.
Bye.